Good morning, everyone. Thank you, Professor Saman Nanakar, the President of the Kandy Society of Medicine, and Dr. Krishna Pradeep, Dr. Nandan Jayatilaka, and the crowd. I am rather like to be here in this very familiar environment to address you today. And actually, on behalf of the President, he is on the way. On behalf of the President of the Sri Lanka College of Sexual and HIV Medicine, I would like to brief you regarding our program. I am really grateful to the organizers actually. As Professor Saman Nanakar, the President said, uh, you all are the first contact physicians when it comes to especially HIV and even STIs. So we are missing some chances actually. So I also experienced recently several deaths. So one story is very recently a patient presented to the A&E with a severe SOB, and finally, actually, I examined this patient. I got a message that one of our newly diagnosed one, still not on ART, presented to the A&E with a very extreme condition. So then and there, we tried to actually manage that patient. Fortunately, we could come to a proper diagnosis. Otherwise, I think I accept that it as our fault, not sensitizing you all in time to time. So yesterday also there's another incident at Polonnaru. There was a patient admitted to Ward 30, OBS, I think gynae and OBS, with fevers and stories like this. We detected a commercial sex worker 8 months back with HIV. We have a team working doing outreach work. Those are NGO people. They visit to brothels and they do self-testing. Through self-testing, we detected this lady, 22 years old lady, and we confirmed the diagnosis. And thereafter, that lady was missing. Then my team went hunting her far deep in Polonnaruwa, Arlagangville area. So when they actually throughout the journey, they contacted me through WhatsApp and other ways. So I instruct that particular lady was not there, and the husband was there. Husband means living together partner, and they did again the spot test, became positive, and the following day we managed to admit this lady to the Polonnaru hospital, and still the VOGs and those people, they don't know about, unaware of this condition. They are managing with what is the available resources. So that's our duty to converse with the other doctors, because first contact, you all are the first contact patient when it comes to STIs or even HIV, except few. I'll say few, maybe herpes, maybe gonorrhea. These people are coming to us, but especially syphilis also coming to our other physicians, maybe GPs, maybe the VPs, and all. So it's our duty to sensitize you all. Whenever we get the chance, we are up to that. So I am really grateful to the Kandy Society of Medicine for giving this opportunity. And without wasting much time, I'll invite Dr. First lecturer is Jagat Thanamaka, the consultant at Teaching Hospital Kandy. Over to you, Jagat.
Good morning, everyone. I first must convey my thanks to Kandy Society as well as our College of Venereologists. And my topic is what is new in HIV. I mainly focus on certain area before going to have a new era. Uh, I would like to explain certain general idea of the HIV epidemic. This is my just outline of lecture. Uh, First we go to the epidemiology global. You can see there is a drop of new HIV infection as well as HIV death due to introduction of antiretroviral to the program. So this is the global, and global at the by the time 38 point plus million HIV people are living. But you can just observe the new HIV incidence and also death coming down because due to introduction of antiretroviral treatment. Uh, so when we analyze the global population, the mainly those infection are concentrated among the key population. So like sex workers, people who are inject with the drugs, and gay men, and also men sex with the men, and the client of sex workers. Those are the main key population which govern the HIV epidemic in the globally. It is very similar to our local data as well. And coming to the local situation, again, those are the main identifiable key population who runs HIV epidemic at the moment. Mainly men having sex with men and female sex workers, beach boys, transgender women, IV drug users. Certain time there may be other vulnerable groups as well, because vulnerable group may be vary with the within the country, also in the place to place and time to time. Uh, so you can see this pattern of HIV epidemic. This represent from 2011 to 2002. You can see there's a upward trend. But compared with the 2002 to 2001 to 2002, there's a 48 increase of HIV cases. It may be due to rapid. One thing is due to true rise of HIV incidence. So sometimes it may be just a combination of enhancement of expansion of HIV testing facility. So at the moment we are having approximately 550 600 people are diagnosed each year. And when we analyze the local part, again, you can remember this is more comparable to the global pattern as well. And the key populations, mainly men sex with men, represent our main burden point. Now, up to 2017, Sri Lanka's main HIV mode of transmission of HIV epidemic was heterosexual mode. But from 2018 up to now, that epidemic is shifted to men sex with men. So you can just understand what is the burden, especially when we consider the men sex with men population. And then sex workers and transgenders very few, and beach boys and casual sex and other things, client of sex partners. So 80% is it not clearly reported due to mode of transmission. Then this is the pattern what I explained just before. From 2011 to 2021, this is the each year MSM total men and women between 18 to 24 years age group. So this is the main age group who got the HIV infection. And but you can just compare the male and female sex difference. So females, as at the beginning, also very similar to the same strength of burden contributing to the HIV epidemic currently, but compare the male, so you can see there's a marked rise of HIV incidence among MSM population. This is really due to transmission factor. So this is just to complete the thing, and this is the main, we know, main mode of transmission sexual. Of them, the highest risk exposure was receptive anal sex. That means person who open anus. That means there's a, why it is more high. There's a high chance of getting trauma. Even with the ulceration, even micro ulceration can be occur, through which HIV and other STI can easily transmit to the person. So coming to HIV testing, so I am mainly focusing the what is the new in HIV. So before that, I want to just touch. So that's why I'm just talking this thing. HIV testing, there are two categories: screening and confirmatory. Screening lab test, ELISA and particle augmentation. What they are the most popular test what we use. We are using at the moment fourth generation ELISA test. It is combined with antigen and antibody detection. Antigen part represent the P24 antigen. And point of care, those are at the site of screening area. What we use is HIV rapid test and HIV self test. And confirmation mainly done by Western blot or line blot assay, which is done only at Central STD Clinic Colombo. And now there's that trend is try to shift to another category, because it take a lot of time, at least minimum 2 weeks time to get confirmed. Now newer technique is WHO introduced to the world quality control 3 different type of rapid test we use for that purpose. That means when we introduce one rapid test, quality control rapid test, if it is reactive, then we do another 2 different quality control rapid tests. If 3 tests positive, we can confirm the HIV infection. So we just need 40 minutes to confirm HIV infection. At the moment, that is not established in Sri Lanka as a program, but still we are using that method to confirm the HIV test. But for the time being, we are still sending sample for Western blot. But we can confirm, we can convey the message to other physician. Your patient is almost positive and can consider and can be managed as in that way. So this is the point of care rapid test, and there's a or a quick test what we use for people who are difficult to reach. Those things we can introduce self-testing or a quick test, and it has fairly, compared with the other thing, has a fairly longer window period. So we not encourage this test for the people who can access for testing. This is mainly designed for the remote, the people who are hiding in the society and not coming to the routine program. This is the days following HIV accession positivity, and we know the molecular diagnosis, and then antigen antibody, various type of thing, and the later Western blot. So earlier we used first generation ELISA. It took approximately 3 months of time to get the test result positive, and but later now we are using fourth generation ELISA. We can markedly shrink the window period. Sometimes there's almost 1 month we can detect, but this is not the only factor which determine the window period. We know that this is the, again, it will depend on the rate of antibody production of individual as well. So I just try to because we know that HIV infection, it has a once it acute HIV infection presented with the symptomatically, it is almost around 60 to 70% patients are symptomatic. But of them, most of people may visit doctor, but almost no one will be diagnosed at that point, because they may put into just common bucket, viral bucket. So we'll say that kind of reassurance is going on, because our a lot of doctors, they won't ask sexual history. If the person says, I have recent past sexual exposure, and this PY is very important, that it may be a rapid HIV, acute HIV infection or seroconversion illness. So once patient become after that acute HIV infection, then there's a long latency period. So that's why we use that opportunity as a window of opportunity, because if we miss that part, then there's a long latency period. If the person carry high risk behavior, so patient transmitting infection to a lot of other people in the community. Right? This is life because I want to much concentrate to other point. It is not moving. Not,
You have put these things.
Okay. Thank you very much. So this is the regarding rough idea, because we may have some idea of antiretroviral treatment, because there are various group, and those are mainly focused on the blocking of viral enzyme, entry inhibitors, nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, integrase inhibitors, protease inhibitors, maturation inhibitors. So there are various drug classes. I won't discuss much thing, because at least if the doctor have some idea regarding the drug classes of HIV antiretroviral treatment, it is good, because this is mainly focused on blocking and viral enzyme. So now this idea is, when we start antiretroviral treatment, now as example, if we detect new patient with high viral load, and if we start antiretroviral treatment with the good drug adherence, then we can achieve viral suppression around 4 to 6 month time. So if the person become virally suppressed, that means undetectable. Undetectable means our threshold is 20 copies, less than 20 copies per ml, patient detected as undetectable. So if the patient is undetectable, then transmission from that patient through the sexual is very low, very low. So almost like you mean equal to you, undetectable. If the person undetectable, patient almost unable to transfer the infection to another person, even with the unprotected sexual exposure with the another person. So idea is to this idea is represent the fast track introduced by the UN to the world. This is the target by the 2030. We plan to end AIDS by the 2030. That target is achieved by they have given three indicators, 395s, because first 95 represent. Now, as in our country, when there's an estimated population, more than 95 people should be identified. For that, we have to expand our HIV testing facilities. So, patients should be identified when the patient admitted to the ward or clinical setting, or even in the society community. Those patients must be identified. So, first, the important point is we have to expand testing facilities. Sometimes we may come across patient, but we not suspect, and we may not offer the HIV test. And second 95 represent of the patient who diagnosed, and more than 95% should be commenced with antiretroviral treatment. So that thing can be easy. When you diagnose, those patients are drained to the STD clinic, and we can start treatment. And almost patients who are in our care almost start with the treatment. And then third 95%, and of the patient who have been started treatment, more than 95% with the good drug adherence should achieve viral suppression. So when there is viral suppression, then there is very low viremia, then destruction of CD4 cell count is very low, then patient can maintain immunity, then there is no place for opportunistic infection, then that means there is no AIDS. That's how we plan to end AIDS. So this is the Sri Lankan data in last year. We diagnosed 82% of the estimated population. Of them, 98 one been introduced treatment and 95 achieve viral suppression. That's how we plan to end AIDS in Sri Lanka. This is given the global by the UN AIDS. So regarding the HIV prevention, there are a lot of modalities. So I may concentrate certain area. You may aware those most of the thin and, but I try to concentrate some area regarding the HIV prevention and management. So we know a lot of vaccine trials are going on. Some those are the latest one, but almost they stop. They have given up because due to low rate of efficacy, because development of vaccine is the problem. Unlike in the other form of virus, there's a rapid mutation and lot of barriers to develop HIV vaccine for HIV infection. So that is, but future maybe there may be an answer. And other thing is voluntary male medical circumcision. This is also old thing, but people are not much aware regarding, because this is also proven by large clinical trial carried out in African countries. And because when there's a male circumcision, it make a outer area, that's a glans penis get keratinized. Because when there's a prepuce in the intact, the underlying area of the prepuce, there's a lot of Langerhans cell which are very supportive environment to catch the HIV virus. So when we do the circumcision, it remove that favorable environment, and automatically that glans penis become keratinized epithelium, unkeratinized to keratinized epithelium. It acts as like a natural condom. It's act as a natural condom. So then it is recommended, especially with the high HIV prevalent countries, for as a HIV prevention method. And other thing is a pre-exposure prophylaxis. Those are the new area I want to just discuss. So this is mainly designed for patient who try to expose patient with HIV positive. Before getting exposure, we plan to give some kind of remedy. So that is the idea, pre-exposure prophylaxis. At the moment, we are using two drugs combination, and there are some studies which have clearly shown there's a reduction of HIV incidence among those population by introducing pre-exposure prophylaxis. The short term we are using PrEP, introducing PrEP. Idea is there are various regime that suppose this is designed for a daily PrEP, designed for heterosexual women, transgender women, and IV drug users. Now suppose now as example, if that person now HIV positive patient may coming from abroad, as example, then that person, woman know that man, when that man is coming to the place, and before 7 days she can start, if the thing is very difficult to negotiate by using condom, and if she is thinking, so chance of getting infection is very high. So in that situation, she can take treatment because those are offered in our clinic. So you can even refer if there's a patient having potential risks in close near future, and you can refer those person to have a PrEP, and then expose your partner. And daily regime is daily tablet with the tenofovir emtricitabine combination, two drugs combination, and daily dose is given. Then throughout the exposure period, we'll continue the same treatment, and after possible last exposure, again person has to continue another 7 days. But when we introduce, this is individual ways. When you have suspect or when you need that service, you can direct those patients to the STD clinic. Then we individually assess, and then because before introducing antiretroviral drugs, we have to do certain investigation, and those things will be done and managed at the STD clinic. So this is daily prep regime. Before that, before and after, person has to continue 7 days, 1 week treatment. And this is event based. This is mainly designed for MSM population. Now suppose because there's a lot of good very established network, sometimes one person may give a call, Machang, I may come today evening, so we may have fun. So that person have, because that person may think, so that person is having no HIV person or non-HIV person or coming from high prevalent area or having high risk behavior. In such occasion, then he can have a pre-exposure prophylaxis. But this does not mean that we should not depress or discourage other preventive methods, using of condom, and those things should be intact there. And in addition to that, so they can have treatment 2 tablets at a time within 2 to 24 hours before the exposure, then have exposure, and after that he has to continue another 2 days in the daily tablet. Or if there's a recurrent exposure for a considerable period, again he has to continue daily treatment, and after last sexual exposure, he has to continue another 2 days. So this is event driven thing. This is mainly designed for men having sex with men. And there's another thing, this is not available in our country. This is recently approval given by the FDA. Pre-exposure prophylaxis with long-acting cabotegravir injectable preparation. But before that, they have to take one daily dose for 1 month, and then this can be taken every 2 months if the person having continuous potential risk. So that person's ideal for this kind of regime. So, and this is, there's a other way that, but this is there's a pros and cons as well. Microsite using dapivirine vaginal ring, but again this is not again available here. But efficacy, there's some time it is not totally clear, but there's some reduction of incidence of HIV infection. And other things are post-exposure prophylaxis. Again, post-exposure prophylaxis, we can divide into 2 categories. Occupational post-exposure prophylaxis, you are very well aware that when you have a needle prick, you may just run to STD clinic and get the thing. Because I mainly concentrate in the non-occupational. Non-occupational mean, if the that is short term is a Pepsi, that means post exposure prophylaxis after sexual exposure. So those terms are important to remember. It is easy to remember, Pepsi, right? So if the person had risk exposure, then we can offer treatment. Now last week we had one patient, and that patient and my partner is having HIV positive. Then I came to know last night, and that patient visit 1 day later to the STD clinic, but we offer the treatment for that patient, right? So this is post-exposure prophylaxis who have exposed with the person with high risk population and or non-HIV patient. Treatment should be started within 72 hours. So that means that point is important, because when you have that kind of person, immediately direct to the STD clinic, because that time gap is important to introduce antiretroviral treatment, and we have to assess individually those patients, and then with the indicated person will be managed. Occupational post-exposure prophylaxis, I think you are aware already. I am not much concerned, because now again I want to highlight some point. When you have in accident that, as example, needle prick, do the basic step, and that area should be washed with running water, with soap and water, and then cover the area, and then come to STD clinic. If you have a sample of the source person, that is important, then we can do the test, and we can get the immediate decision with that by applying rapid and test for source sample. So that time is important. So non-occupational post-exposure, that it means Pepsi. So this is specially designed for risky sexual behavior people. The time period also important, but decision is taken by us, because sometimes you just direct those person to the STD clinic, then eligible persons are given treatment. This is the indication for main PrEP. We can divide into two categories. The source person may be known with HIV positive. If the source person known with HIV positive, if we know the viral level, if it is viral load level, then we can very easy to get the decision. And so if the person having, now as example, if the HIV positive but viral load is detectable or unknown, if the person had a receptive anal sex or insertive anal sex or receptive vaginal sex, those are the indication for introducing antiretroviral drugs within that short time period. If the person HIV status is not known, and then if the person coming from high risk population, as example key population like MSM group or sex worker or client of sex worker, and in such occasion receptive anal sex is an indication, but insertive anal sex we may consider. And in other setting, though we not introduce, not recommended, patients, those persons are counseled very well, and then other services are also delivered to the patient through the STD clinic. Right, those are some website people can access. Those come as a soft as a mobile phone app, so one can use those things to get the service and assess the risk level and those things. Right, thank you very much.
Thank you, Dr. Jagatranawaka, for that informative and interesting presentation. I'm sure there will be lots of questions from the audience, but we'll have the questions at the end of all 4 sessions. Our next speaker today is Dr. Tilani Ratnayaka. She is the president of the College of Sexual Health, president of Sri Lanka College of Sexual Health and HIV Medicine, and she is the consultant mineralogist at STD Clinic, Anuradhapura. Dr. Tilani Ratnayaka is going to speak on prevention of child sexual exploitation and what's our role. Over to you, Dr. Tilani Ratnayaka.
16th. Done. Let's stop until he get the thing sorted. Good morning, good morning, everybody. It's nice to be here again in Kandy. And on behalf of Sri Lanka College of Sexual Health and HIV Medicine, I would like to thank Kandy Society of Kandy Clinical Society and Professor Saman and Council for giving us this opportunity. So we'll quickly move on to the presentation now. So I'm going to talk to you about child sexual exploitation and how we can prevent this within the health system. So this is okay. So we are going to talk about some definitions. We need to clear about some definitions, and we need to know about some global and local situation about what is the situation. We don't have true or complete figures, but some figures, and what are the adverse outcomes of child sexual exploitation and early warning signs of child sexual exploitation and safeguarding children. That is kind of a sharing of experience with you. And I will start my lecture with this question: what do we hear every morning? So these are the things. Sadly, if you listen to the news, TV news, or look at the morning daily newspaper, these are the kind of news about children these days. These are some of the paper cuts I collected during last 1 to 2 months. So child sexual exploitation, kind of disturbing problem nowadays, and sometimes it's really bad, and we have to question from ourselves whether this is true or whether this is a fake or what's happening. So as health professionals, I think we also have a duty to look into this problem and what we can do about it. So before go into that details, we will clear about some definitions. Sexual exploitation. Before child sexual exploitation, I'll tell you what is sexual exploitation. It's kind of a broader definition. It refers to any actual or attempted abuse of a position of vulnerability, differential power, or trust for sexual purposes. And sexual abuse is coming under sexual exploitation. It's kind of a narrow down from, but maybe more serious. Is the actual or threatened physical intrusion of a sexual nature, whether by force or under unequal or cohesive conditions. And these, so although the definitions are quite a lot of words and phrases, under this there are several activities or acts come: rape, prostitution, sexual photography, subjection to sexual pornography, or witnessing sexual acts or sexual assaults or sexual acts to which the person has not consented. And this sexual exploitation can happen to adults and children, and it can happen at anywhere, at home or on the street or online, at any place. There's no boundaries. And when it comes to children, what is child sexual abuse? It defined as interaction between a child and an older child or an adult. And this adult can be a stranger or sibling or a person in a position of authority, such as a parent or caregiver. And when the child is being used as an object for the older child's or adult sexual needs. And what are the figures for us? So if you look at the world, it happens everywhere. So estimated prevalence for child sexual exploitation, they say for girls it's somewhere around 8 to 31%, and for boys it's 3 to 17%. These are figures from UNICEF. And UNICEF, I like this phrase, uh, sexual violence knows no boundaries. It occurs in every country across all parts of the society. And so in the world, they say cumulative number of 120 million girls under 20 years of age have been forced to engage in sex or perform a kind of sexual activity in their lifetime. That is something like 1 in 10. And 90% of adolescent girls who were forced to have sex is by someone they knew, very close person of them, maybe a boyfriend or husband. And sadly, these are the figures reported, but there may be thousands and millions of figures that are not reported. So especially related to the boys. And actually we are seeing the tip of the iceberg. There may be many cases that are not reported due to various social and cultural reasons. So what are the figures for Sri Lanka? So Sri Lanka, we get the figures from the authority. The best place is to go to the National Child Protection Authority, NCPA. So according to the NCPA, they say per year there are about 8,000 to 10,000 complaints related to different types of child abuse to NCPA. Out of that, close to 1,000 or 8 to 14% are related to child sexual abuse or child sexual exploitation. So I will show you the figures for the 2022. These are the figures. The highlighted ones are the sexual kind of abuse for children in Sri Lanka. They report under different categories: sexual exploitation, sexual harassment, rape, incest, and grave sexual abuse. So every year throughout the year it comes to close to 1,000 or somewhere. So we don't have many or complete figures to show you, but I collected from different places and different studies. According to these sources, there are very number of children in sex industry in Sri Lanka. According to some sources, it goes up to like 36,000 children are engaged in a sex industry in Sri Lanka, but I'm not competent enough to give you a comprehensive record of these things because we don't have enough figures. And these are the districts that district wise how it was the child abuse was reported according to the National Child Protection Authority. And so as we don't have enough figures, I thought of looking at my clinic and what's happening in Anuradhapura. So to give you a best example as far as I can. So in 2021, in Anuradhapura, JMO reported 107 cases of child sexual abuse, and to police, that is Children and Women's Bureau of Sri Lanka Police Anuradhapura, dealt with 207 cases of children after sexual assault, and District Child Protection Officer says they got 91 cases. So you can see different stakeholders dealing with different numbers and significant number. So this is the figures from Sri Lanka Police Anuradhapura for 2021, 207 cases under these categories: rape, serious sexual assault, and incest. I think these are somewhat confirmed cases. And so we will look at what are the adverse outcomes of child sexual abuse. I don't need to tell you in detail. I think as medical professionals, we know how serious these adverse outcomes are. It can be severe physical, psychological, or social harm. They can end up in sometimes suicide, or they can lose their lives. I think you all have heard what happened in Kalutara last month. So maybe that is one good example how serious is outcome can be. And sometimes After sexual assault, they can end up with pain, unwanted pregnancies, increased risk for HIV and STI, and sometimes social isolation, psychological trauma, depression, and some children change their behavior, and they engage in risky behaviors like substance abuse or to cope up with the trauma, and some, not only on the child but also on their families, can have negative effects. So this is where I work, STD clinic Anuradhapura. So I look at what am I dealing with in 2021. We saw 51 children under 18 years of age, and out of that 30 were after sexual assaults or referred by JMO. And sadly, 8 of them ended up with having sexually transmitted infections, and we treated for these children, 8 children, for syphilis, genital warts, and herpes, and 3 children ended up with unwanted pregnancies. 2 were in 17s and 12 were in 12. So I don't know what happened to their future. So this was really unfortunate outcome. So what are we doing in sexual health clinic or STD clinics if a child or adult comes after sexual assault? What we do is we screen for sexually transmitted infections, chlamydia, gonorrhea, syphilis, and HIV. Sometimes, depending on the facilities available, we do screen for hepatitis B, and we provide some prophylaxis treatment for hepatitis B, vaccination against, depending on the facilities available, and post-exposure prophylaxis for HIV if they present within 72 hours. And sometimes, depending on the seriousness, we can provide prophylaxis antibiotic for chlamydia and gonorrhea as well. So these are the things we are doing, but beyond that, we don't look into a child's future or we don't have the capacity. So when we analyze or when we study these cases, we see most of the child sexual abuse cases are not happen as a sudden provocation event. So most of these children were living in an unsafe environment or groomed by a perpetrator for some time, and during that time they would have come into contact with many authorities, especially in health and education. So if for example, last month I saw a child who was 15 years old, sexually assaulted and presented to us with herpes, but that child was going to school for so many years, and many health professionals would have come into contact with her, but no, and she was going to school, and any of those authorities did not detect that child was in an unsafe environment. So why are we not spotting these signs? So that is what we need to look into. So maybe we don't know the signs. Maybe a child is showing the signs, but we can't identify, or lack of awareness, or maybe we are not bothered. It's not my problem. Until it happens to your own daughter or your own son or your own younger brother or younger sister, sometimes you're not bothered, isn't it? And sometimes we are bothered, but it's beyond our capacity. Maybe we don't have time, maybe we have other things to do, so it's beyond our capacity, and we don't have power to provide that service and no facilities. Maybe that is the reason. Sometimes, although we sometimes we take extra effort and go beyond our boundaries and try to help these people, but the system is not working. So for example, if somebody wants to tell or complain that child is in a dangerous environment, if something will happen to this child, and they want to complain to somebody or some government officials, they have to go and wait for hours and hours. So we are not, the system is not very favorable. Whether you agree with me or not, there's a system in Sri Lanka, but it's not very user friendly when it comes to this kind of things. And maybe the stigma. Most of the time when there's a child abuse or child sexual exploitation, stigma is attached to it. Not only the child, but the family members and people around them try to hide it, or because of the stigma. Okay, so how do we identify the risk? So we need to know a little bit about how to identify a child is at risk or living in a risky or unsafe environment by looking at child as well as a child's family or the environment the child is living. Sometimes this can be a factor within the child, like a behavioral problem or mental health or lack of assertive skills, or sometimes maybe the family, like parent problems or single parent, bad parenting, poverty, lack of awareness, and sometimes it could be the environment that child is living. So maybe the poverty or lack of a proper system, gaps in the law. So there are so many. I'm not the very good competent person to talk about the law, but there are gaps in the law and policies and peer pressure, drugs and alcohol. Those are the things within the environment that we can spot and identify that this child is at risk. So we will talk about what are the early warning signs of child sexual exploitation. So to identify that child is at risk, we need to know what are the signs. There are many, maybe within the child, as I say, or maybe family. We will talk about some of them. One is a family. So the main protection to a child comes from their parents. If the parents are not there, the child is at risk. So no parent protection at all, maybe due to natural reasons, and maybe child is living under a single parent due to death of a parent or long-term illness of one parent, or maybe a divorce or separation of parents. Those are social and natural things. And sometimes in Sri Lanka, most of the authorities says mothers going abroad for employment is a very high risk factor for child sexual exploitation. I don't know whether you agree with me or not. So if you talk to many government authorities, even if you talk to some health professionals, they will agree. And in one side, it's right. So it's right. Every mother who is going abroad should be responsible that until she comes back, the child is in safe hands. That mother's duty. So yes, we do agree with that. But on the other side, if you look at this phrase or this statement, when the mother is not there, the people around that child or adult males around that child is going to rape that child. Is that what we are saying? In other words, is it like very primitive society we live in? So you have to analyze this phrase in both ways. So when the mother is not there, everybody around or adults around that child, they are going to rape that child. Is that what we are saying here? So until that mother comes back, child should be safe in this environment. So it again gives us an indirect indication our environment is not safe. So bad parenting. So parents involved in drug dealing, sex trade, with within the domestic environment, parents addicted to alcohol and drugs, and sometimes their extramarital partners can be a threat for children. So it can be a risk for child sexual exploitation. And when it comes to teenagers, sometimes we see this problem, bad parenting. So not understanding the child properly. So this happens it can be seen in many parenting or most of the time, but sometimes this can go into extremities, and parents and children relationship can be broken down, and child can run away from home and ended up in somebody else's as a victim of child sexual abuse. and missing from school. So again, this can be a very early warning sign of child exploitation or child stepping into another danger. So this can be very easily spotted by teachers or authorities in education. But in our society, this is kind of a normal thing. When the children are in their O levels or after O levels, most of the children are not going to school, and we take it as a no. I'm not talking about that category here, but sometimes when children are not coming to school, it can be very easily spotted and taken some actions to prevent what his child is up to. So and prevent any dangers happening in future. So in what we need is a properly functioning system or alarming system. For example, if you think about your child, if your child is not going to school, the teacher is going to ask about what her or his absence on the next day or maybe 2-3 days afterwards. But in some other countries, there's an alarming system like if your child is not going to school, you have to inform the school on the same day. If they don't receive a message like that, they are going to ask from the parents on the same day, maybe within few days from start of the school. So those things are very easily established and very easy things to do within our system, but and very important things very early steps that can be taken to prevent child sexual exploitation or any other dangers like stepping into alcohol and drug abuse. And then I will like to talk about child grooming. This is kind of establishing an emotional connection with a child under the age of consent, and sometimes with the child or sometimes with the child's families, to lower the child's inhibition so they can manipulate or exploit or abuse them. So it's a step-by-step process. We have seen in many cases that child is not abused in 24 hours. So this perpetrator is making the environment favorable for to get the child into isolate from the family, and step-by-step process they are going to this abusing process. So child grooming is a very well known and very easily identified early warning signs of child sexual abuse. So what are the steps? So if you know, I think most of you, there are pediatricians or doctors working in the pediatric, they may be more competent about this. What are the steps in child grooming? One is identifying and targeting the victim, and sometimes gaining trust and access. Especially we see this by giving presents, extraordinary valuable presents, money to children, and playing a role in child's life, and then isolating the child step by step from the family, and then creating secrecy around the relationship. And this grooming person become a very big role model in child's life. And then initiating sexual contact, and ultimately at the end they break the physical boundaries and controlling the relationship after abuse the child. So what are the signs we can spot on very easily from the child? If a child is receiving expensive gifts, especially like mobile phones, money, or handling money at in big amount, this can be easily spotted by teachers and parents. If parents are aware of this factor, and the teachers are aware of this phenomenon, they can easily identify who are the children are under grooming or subjected to groom. So they need to ask about. Sometimes what happen in our society, if very poor family, if somebody is helping the child, they will take it as a present or is at a very positive way, rather than thinking twice whether the child is going to a dangerous situation. The other early warning sign is a negative peer pressure. It's most of the children like to stay in groups. They have always fear of being rejected from the group. Sometimes this peer pressure can be a negative one, and they are pushing some children to drugs, alcohol, and inappropriate sexual relationships. So how to overcome? So this child need good parent support or family support, and they need to know how to say no, or assertive skills, life skills. This has to be given to children during their school education. And relationships. We know this is not a uncommon thing, and I'm not here to talk about love affairs or relationships of school children in Sri Lanka here, but it's a different topic. But if a child is having a relationship with an adult, especially if that person is more than 5 years of age, there's a possible power imbalance in that relationship. So the older person can control the younger person, and ultimately can lead to a child sexual exploitation. If we spot these things, we need to intervene, but not in inappropriate way, very sensitive manner. So adults or health authorities or authorities in the education sector should know how to deal with these situations and take the child out of the danger. And obviously, alcohol and drug use in early age, it is obviously a risk factor for child sexual exploitation. I don't need to explain it in detail, but we will see what is the prevalence of drug and alcohol use among school children in Sri Lanka. This survey was done in 2016 among 3,000 and something school children between 10 to 19 age, and they found about 3.4% are using alcohol and 2.7 are using illegal drugs. The situation may be different now, but these are the figures I got. And the other factor or other sign I would like to talk about here is online sexual harassment and online sexual exploitation. So this is defined as when someone receives unwanted sexual content or on a digital platform. It can be a nude image or video shared with them online. So this is also called sexting, and this can include many activities like so this is broadly what is online sexual harassment. It can be spreading rumors or lies in sexual nature, or sometimes it can be sharing a nude image or video and without their consent. And this can be even photoshopping or editing an image or video of someone in a sexualized way. Or sometimes it could be sharing sexual image or claiming it to be someone else's in order to embarrass them. And sometimes it could be sexualized messages to someone. It doesn't need to be a picture always. It can even be a text message. And sometimes sharing a link to a website, and it can be a link to a porn webs or something like that. Sometimes sending sexualized emojis also comes under online sexual harassment. And what is the law here? So the law says that creating or sharing sexual images or videos of a child under 18 years is illegal, even if the person sharing is a child. And this could include sending sexual messages, child taking an explicit photo of themselves and sending to a friend. So this is illegal. Most of our children, sometimes they don't know about these laws and things. Without knowing, they do this and get into dangers. So why do children get involved in online sexual exploitation? There may be several reasons. Sometimes they don't know the gravity of it. Sometimes that could be peer pressure. Sometimes that it could be threatened or blackmail. Sometimes it may be a part of grooming or increase their Sometimes children think it is a way of increasing their self-esteem, or sometimes they are trying to explore what is their sexuality by doing these things, or sometimes they try to convey the message that I'm gay or I'm straight by sending these kind of messages and pictures. And sometimes, especially girls, they think when they love to one person, extreme in teenage, they think that is the only person in their world. So they owe their boyfriend or girlfriend, and they feel guilty when they are asked to send a nude picture of them if they don't send it, they feel guilty, so they do that. But later on, this can use as a tool to harass this child, and maybe sometimes if they think this is a joke, just a joke. So what is happening in Sri Lanka? So we don't. So how common is it? We need to know a little bit of figures. So online violence. They have done this study in 2019 with Ministry of Women and Child Affairs of Sri Lanka together with Save the Children, and they found that 28% of children have experienced some kind of online violence in Sri Lanka. This is somewhere like 3 out of 10, and most of the time it was girls were subjected to, and 24 of them talked about this incident to one of their friends, but they didn't talk about this incident to their parents. And all types of platforms are used for this online harassment: Facebook, Instagram, Twitter platforms. And these are the types of online violence. Most of the violence or harassments are under sexual nature: receiving indecent text message, clicking onto a link in a message that shows indecent image of the other person. Those are the things they reported. So then they look into why these children did not complain about this incident to their parents or guardians. Sometimes they were scared, sometimes they were threatened, sometimes they were bribed. Those are the reasons. So after this survey, some good things happened. They have made changes to national child protection by the National Child Protection Authority for laws and policies under Child Protection Act. So I'm not going into details about these laws. And this is a worldwide organization called International Watch Foundation, and they also keeping an eye on child sexual exploitation happening online, and they report as an increase from 1000% during the lockdown period. And CEO of this foundation says a nice advice: parents are often unaware there's that online backdoor into their homes which is leaving their children vulnerable. So this is again, so how to prevent online child abuse or child exploitation. So they talk about this steps or prevent scenario. Talk to your child. Talk stands for T stand for talk to your child about online sexual abuse. And once you brought a phone to a child, you should agree on ground rules with the child, how to use the phone within the family, and learn about platforms and platforms and apps that take an interest in their online life. But here, most of the time, we are learning from children. If you're, most of the time, even that implies to me as well, about apps and platforms. We try to learn from our children, but what they advise is we should also know about these apps and platforms what children are using, and know how to use security tools and setting a security app to your child's phone. So those are the things, those are the important things I want to talk to you about child sexual exploitation and early warning signs of child sexual exploitation. I will now share, if we have time, about some experience about we have done in Anuradhapura. After looking at this problem, and we thought of we should do something to prevent this, and we started this program called Child Safeguarding Program or Rakavarana in 2021. We did a pilot project as well, basically aiming to prevent child sexual exploitation and abuse under the age of 18 years to below the in the district of Anuradhapura. Basically, this is a preventive program to prevent child sexual exploitation by identifying them early. Although we started from health, we are not the only stakeholders. This is a multidisciplinary commitment from the district secretary, health, education, child protection authority and police, and we got all the permission in writing from these authorities, and we are working together as a team, and probation and social services also involved. And these are the steps I basically tell you. This is a very comprehensive, but these are the main steps. First, what we do is identify the children at risk of sexual exploitation by using an informant network model. We introduce this. It's not very complicated, but something methodical way of identifying children at risk of sexual exploitation, and then take them under into a certain working group in the district, and we categorize these children whether they are high risk, intermediate or low risk, and according to that we provide services to each and every child. It's like a case management system, and then we monitor the child until that child come out of that danger. So it's not kind of a program or ad hoc program that we go into a village or school and talking about child sexual exploitation. It is an ongoing kind of system with all the stakeholders involved. So this is informant network model. I briefly talk about this. Here we use trained government officers during their life duties to notify children at risk of sexual exploitation, and we are using a screening questionnaire here. It's like this, it's an informant network model we call. Why this? They act as informant. බුද්ධි නිලධාරී, බුද්ධ්‍යාංශ නිලධාරීන් වගේ වැඩ කරන්න කියලා කියනවා within their duties. Who are these informants? Maybe PHM, PHI, doctors, nurses, especially doctors working in the OPD and working in the pediatric units, teachers, Grama Niladhari, and field officers. And there are many field officers, and under AGA. So for each AGA division, we introduce this model step by step, and we completed the pilot project in Tambutegama, and now we are expanding it to all the AGA divisions in Anuradhapura. And once they identify these children, these informants identify these children at risk during their duties, maybe in the field, maybe in the school, maybe in the hospital, they refer these children to a working group under the AGA. That working group consists of 5 to 10 members led by divisional child protection officer. And there are many officers. If you look at the AGA structure, there are many officers working for children's safety and welfare. And so these officers are trained and asked to work as a working group, and there's a contribution from MOH as well as the women and child division of that area police. So one officer comes into this working group as well. So what they do is, once they receive these cases, they analyze whether this is a true risk or not, and risk is categorized according to a scoring system, and they provide services and monitor the child. So how they screen, how to identify is using this questionnaire. We developed this, pre-tested this, and there are 20 questions in this questionnaire. Anybody, OPD doctor, Grama Niladhari or PHM, when they are doing their job, if they spotted one of any children or any child is at risk, they can fill this form and send it to the working group. So these are the early warning signs we use to develop this tool this screening tool or questionnaire. So we always use these signs and use these signs to develop that questionnaire, and also we try to use these signs to educate children as well as adults, especially parents in the area, about this risk of child sexual exploitation. So this is basically what we are doing. I'm not sure whether you understand what I explain here, but I thought maybe 25% of it if you can understand or if you got it, I'm really happy about it. But this is what we are doing in Anuradhapura at the moment. And I would also like to ask you, look at your figures, look at what's happening in Kandy, and try to do something, establish a safeguarding system for these children within the safe health system, work with other stakeholders, and you can start this by looking at your figures. So always what we should do is not to miss this opportunity to save a child's life. Thank you. It's okay. Yeah. I just took it out. I don't know.
Thank you, Dr. Tilan Ratnayaka, for that eye-opening presentation. You touched the important points on prevention of child sexual exploitation. So our next speaker today is Dr. Chitran Hatrusinghe, the consultant venereologist from STD Clinic Kurunegala. He is going to speak on overview of sexual dysfunctions.
All right, thank you very much. All right, this will be a very short presentation. Actually, we are running behind the time. So most of the time, as medical professionals, we talk about negative subjects. That may be the reason my good friend Dr. Kakula always said, make it very positive and do sexual function rather than doing dysfunction. Anyway, have you ever managed a case of sexual dysfunction in your career? Maybe as a GP, maybe a consultant, VPO, maybe a VOG. If I ask this question, I don't know the response. And do you think this is an important topic? So when I walked through our corridors, a month back, a lady ran into me and asked me whether her husband came to meet me. Immediate answer is no. කවුරුහරි ඇහුවොත් මම හම්බෙන්න ආවද කියලා husband immediate answer is no නේ. Yes කිව්වොත් husband will be facing serious problems. I said no. Then I asked why, what's the matter? So she reluctant young lady, she said to me, I asked my husband several times to come and meet you because she is having dysfunction, sort of dysfunction, a senior staff member. So I said, okay, well, we'll wait for him. He called me just yesterday. So can I meet you today? I said, I am at Kandy today. So we'll meet another day, leisurely. I really appreciate the courage that lady had. So they don't come out with this problem. Yeah, actually this is a primary instinct human being experience. Actually, men are greedy. They say men are greedy for power, mainly for power. That's why no election. The second one is the sex. They say even more than the hunger. And sexual problems are of serious concern and need assistance. They don't come out with this problem because we are not helping them. We are not helping them. Essentially, they don't have to come to STD clinics. They may come to mainly should come to general practitioners, then VPs, VOGs, other categories. So they are not coming because they know that it's not helpful. We are not going to help the people affected by it much more than statistics show. People do not admit their sexual problems due to maybe shyness, stigma, various things. Social stigma is both men and women are affected sexually with dysfunction, but mainly I would say females, they are not coming to our services. Yeah, there are a lot of benefits of sex, as you all know. Everybody like to talk about sex. In TH Krunal, we have a separate, consultants forum for sex. They says THK boys, only the adults only matters they share. Helps keep immune system humming. No worries about HIV. Boost libido. Improve women's bladder control, of course. Low blood pressure. And counts as exercise. You don't have to run on the roads. Ballo tapagin. Neither. You can very well do this. Lowers heart attack risk. It's very important. Lessen pain. Less prostate cancers. Improve sleep. Ease stress. Everybody knows these positive factors. But when it comes to dysfunction, it's actually silently feed on human happiness because of its relation to intimate feelings, activities, and personal content. Sexual dysfunction results in irritation, lack of concentration, disturb marriage life, and disturb relationship. Insomnia, maybe delay in starting family, psychological disturbances. How many youths are waiting? They are postponing their marriage. They say, I have dysfunction. Prolonged case may lead to lack of self-esteem, maybe suicidal tendencies as well. And it refers to a broad range of difficulties or impairment that can occur in any phase of sexual response cycle. Again, we have to go back to our second MB knowledge. And from a medical perspective, sexual dysfunction can be categorized in various conditions. Mainly in male, erectile dysfunctions, premature ejaculations, and delayed ejaculations. And in females, orgasmic disorders, sexual pain syndromes like vaginismus. And again, you can categorize like this also. Difficult sexual dysfunction and difficulty during any stage of the sexual encounter that prevents the individual or couple from enjoying sexual activity. 70% of the sexual dysfunction cases are from above 40 age. Of course, youths are coming. Mainly above 40 people are affected. Many types of sexual dysfunction, as I mentioned earlier also. And this is the actually diagram shows how this impotence comes. Unable to develop or maintain erection during sexual activities. Commonest type of sexual dysfunction is the erectile dysfunction or impotence. More common with as you age. And the sexual response cycle is very important. It's a sequential physical and emotional changes that occur as a person becomes sexually aroused. This is still being studied. We still use the old one, old model, Kaplan's, Must and Johnson 4-phase models, what we learn in our second MB level. And there are 4 phases. Those who are managing sexual dysfunction should be well versed with all these phases. And of course, in case of females, we talk about multiple orgasms. I don't touch these areas because we are running behind the time. So you can go through leisurely. And we talk about female ejaculation. When I just ad hocly talk to males, 90% of males, they don't know about G-spots. Maybe even the doctors. And I actually prepared a video also about this G-spot. Female ejaculation is related to this G-spot. G-spot called as the female prostate gland. Some introduced like that. And meta-analysis of studies of female ejaculation found only 10 to 50% of female experience ejaculation. And we'll talk about male sexual dysfunction very briefly. There's a saying to say that penis is the window to your heart. Penis is the window to your heart. What does it mean? When studied respectively the patients with heart diseases, so they have experience at any stage of their illness, they have experience, they say, oh yes, I can remember, I had this illness as well. When I discuss this with our consultant, I say, ඒක තමයි මචං එනම් මේ කොල්ල කියන්නේ නංගි මගේ heart එක හොඳයි කියලා. Heart එක හොඳයි means penis is good. Vice versa. So you have to love your penis. That's the main message. So even with slightest something going out of the way, you have to investigate. Right. Male sexual dysfunction is any physical or psychological problem that prevents client or his partners from getting sexual satisfaction. My experience is it's a combination. Mainly we have to exclude the physical causes, but psychological causes contribute. It's a common health problem, actually rather common health problem, though these guys, they don't come to us. They never come, because even in the hospital setup, they never come, because we can't treat them right now at least for the hypertension. These drugs are not available, the other modalities are not available. So we have, access in our sexual health clinics for these people also, but they are reluctantly busy. But in private sector, it's common scenario. Treatment can often help men suffering from sexual dysfunction. Actually, the main types of sexual dysfunction, as we mentioned, erectile dysfunction, premature ejaculation, and delayed or inhibited ejaculation, and loss of libido. You can always investigate for the physical causes, disease affecting blood flow, such as hardening of the arteries, lipid profiles and all, the family history, and nerve disorders can, of course, contribute this. And injury to the penis may be penile fractures. And there's another bit common entity called Peyronie's disease. I think some of you may have seen these patients. Chronic illnesses such as diabetes, high blood pressure, maybe thyroid function problems, unhealthy habits like smoking, drinking too much alcohol, overeating, lack of exercise is a main contributor with this nowadays sedentary lifestyle, and sometimes low testosterone levels. And psychological cases, of course, you have to analyze. Concern about sexual performance. When a VOG says, okay, you have to go and sex during this period, 100% they fail. They come to us. So VOG says, you are sex karanda babalane ban karanda. Right? Marital relationship problems. It's very important. Depression, feeling of guilt, effect of past sexual traumas, maybe childhood incidents, work-related stressors or anxiety. This, of course, time-consuming to analyze these. Ejaculation disorders. Word about this. Premature ejaculation that occurs before, soon after penetration. Inhibited or delayed ejaculation is ejaculation does not happen or takes very long time. These are common problems. Mainly, people are coming for premature ejaculation. We categorize premature ejaculation as primary and secondary, and we have to have a good management plan after this, having a lengthy discussion with this patient. Always my advice is to do not examine the couple at once, but never examine single. What does it mean? Always get the, if you have both coming to your clinic setup, talk to one client at once, because otherwise they don't come out with the reality. Sometimes they may have dysfunction with the partner, regular partner, but good function with the other partners. So it's very difficult to analyze these things. Then they get the other partners also once you complete with the presenting complaint of the main client and listen to her or the other partner as well. Retrograde ejaculation is another problem, and there are certain causes for that also. Premature ejaculation, of exact cause is not known, while in many cases premature ejaculation is due to performance anxiety. It's very important, especially soon after marriage. Other factors may be stress, temporary depression, history of sexual repression, low self-confidence, lack of communication or unresolved conflict with partner. Delayed ejaculation, chronic long-term health problem, medication side effects, alcohol abuse or surgeries can cause. Can also be caused by psychological factors such as depression, anxiety, stress or relationship problem. Retrograde ejaculation is another, not rather common, but another variety that patient present to you is most common in males with diabetes who suffer from diabetes related nerve damage problems with the nerves in the bladder and the bladder neck force the ejaculate to flow back. Retrograde ejaculation may also be a side effect of some medications. That also you should take the drug history as well. Low libido mainly due to low testosterone level. Low testosterone level may be due to various medical causes. So you have to test for these. And reduced sexual desire may also be caused by depression, anxiety or relationship difficulties. So you have to do thorough investigation regarding these. And there's another new variety coming up, cyber sex. It's also another common one. So I have got several cases of youths just after marriage. They are coming to us just after marriage. So when you take the history carefully, they are addicted for pornography extremely. So once they are addicted to pornography, that they tune in a different way. So they can't have a good sexual relationship in real life. These are new, very difficult to manage these cases. The new varieties of sexual dysfunction. And how do you diagnose? Diagnose mainly clinically and relies on sexual experience of the individual. It is actually rather time consuming, and you can do blood tests, sugars, cholesterol, thyroids, testosterone, whatever. Neurological assessment is mandatory, and sometimes we offer duplex ultrasound and to evaluate blood flow and all. Diagnosis tests depend on the clinical history. And of course, treatment, there are several treatment modalities. So you have to always think of a combination of these treatment. That just giving sildenafil or avanafil or varnafil wouldn't help. So you have to combine with these other modalities. Actually, psychosexual therapy is very essential in these categories. So the other methods, vacuum erection devices for prosthetic implants they are using very rarely. If you manage these patients' physical as well as psychological aspects, you can yield good results. So only thing is we have to motivate these patients to come to medical services, especially to GPs, then to relevant specialties. That is the most important thing. When we see patients in, say, as example, private sector, 90% of people are coming for these things, not for STIs, not for, of course, it may be HIV or other, not for those diseases, mainly for sexual health problems, whatever. And the alprostadil also we are using, maybe intracaverous injection, maybe intraurethral alprostadil, but keep in mind about side effects as well. And penile pumps are there. Penile implants we reserved for extreme cases. It's very rarely done in Sri Lanka. And some ask about shock wave therapy also. Still under study these areas, you can use this, but results, that of course depends. We have to select the correct candidate for these bit expensive modalities. Better to discuss a word about female sexual dysfunction. It's rather neglected area, actually rather neglected area. I can remember when I delivered a lecture for for health staff in a rural MOH area. Suddenly, after the lecture, primary care health worker came to me and said, "Sir, when I do field visit, a lady came to me and complained about sexual dysfunction." So we investigated her and found something actually seriously wrong with in her brain actually. So of course we need multidisciplinary teamwork to investigate these. Unfortunately, these females, they don't come to us. They don't come to medical services. That is what we have to do to whatever we can do to motivate them is very important, right? Rather neglected field. As I said, problem is often multifactorial. This is a multidisciplinary evaluation. They are not coming essential to STD clinic, as I said, I mentioned earlier also. If a patient complain to you, even if patient have just signaling to you about these problems, please analyze. If you don't have time, please refer to the necessary, relevant areas. We have to address the biological issues as well as psychological issues, socio-cultural issues, and relationship factors. And everything is related to these dysfunctions. So when we, sometimes we found, cases of HIV. They have gone to, these services, sexual health, sexual services. When we ask the reason, they say wife is not interested. So that's why I went to these places. The other way around is the sexual health workers. There's a very big demand. Just I got a young girl, beautiful young girl of 22nd with HIV positive test. When I inquire, she said these. When I said that you have got this thing, she just laughed. She's the breadwinner of the family, and she says, her madam running 3 places. One is at Nuwara, one is at Kandy, one is at Kurunagar. They, allocate these people to various places, and there's a high demand. When I asked who are the people normally coming, mainly middle-aged people. So everything related to this thing, and we have to concentrate a bit on this female sexual dysfunction. Of course, men used to come. Some or other they got to know about these services. They used to come, but female very rarely they are coming. I can very well remember once a patient came. Once a lady brought a patient to me. Lady herself is talkative and talked to me and sir, my husband is having sexual dysfunction around 40s. So she further said, she's not that educated. She further said, I am not that interested about sexual this life, but I suppose this patient is having something else. By looking at her, I could diagnose cirrhosis that turned to be non-alcoholic fatty liver disease. So that's how these things work. So that poor lady with, I think, educated just maybe up to grade 5 or 6 could brought her husband for this problem. But as medical professionals, we have to pay attention to this problem as well. Please keep that in mind with your very heavy workload in your specialties. And if you further discuss these things, there are very interesting points. As we are running behind the time, I'll skip these parts. Treatment depends on the etiology, and estrogen sometimes maybe estrogen and combination therapy and testosterone. There's a drug called bupropion. Sometimes we can use selectively according to the problem, but still under research. And psychotherapy or psychosexual therapy is very important in these patients. Rather time consuming. You can't do it in a very busy setup. So my experience in psychiatry department also, they are not happy because they can't, with their heavy workload, unless they have a separate clinic setup for these people, it's just not, working. So we have to have a dedicated services. We are trying at our sexual health services to offer them these services. I think Kandy, Dr. Jagat also may be offering the service at least reserved few days for sexual health. Please try to manage at your level, or we can have a multidisciplinary teamwork when these because there's a dire need actually. That's why I am stressing these. Clinicians can address many of these issues. Maybe endocrinologists, maybe gynecologists, maybe STI people, maybe psychiatrists. So when it comes to vaginismus, rather difficult case to manage. It's fairly common. Some says it's maybe 20 to 30 females are suffering from vaginismus. They go and get surgeries done even. It's common. Nothing going to help. So we have to do multidisciplinary teamwork regarding especially women's, I am stressing, women's sexual health problems, especially women's sexual dysfunction. And there are a lot of varieties of sexual therapy, cognitive behavioral change therapy, emotional based therapy, mindfulness based therapy, some other interventions, couple communication techniques. There are a lot to do. And sex therapies, there are sex therapies. I think in Sri Lanka we have only few, isn't it, Dr. Karavita? Do we have more? No. Very difficult to have sex therapies because they need to have extensive training. Just say in UK, it takes 9 years to be a sex therapist, right? This this may be the most interesting slide when I do lectures for my audience. So I think I just could manage it within given time. Right. Thank you very much.
Thank you, Dr. Hadra for that brief yet informative talk. Our next speaker today is Dr. Iruka Rajapaksha. She is a consultant mineralogist from ACT Clinic, Madali, and she is going to speak to us on sexual and gender diversity.
Not this one. This is the previous one. Is this? No. Yes, this one. Yeah. It's from the pin, no?
It doesn't matter.
Okay. What is this? Right. Okay, thank you. My topic is sexual and gender diversity. So when the term diversity means many things to each of us. So historically, we call we categorize people as a man and a woman, and we always see heterosexual relationship, man fall in love with the woman and all. But things are changing, especially in 21st century. We see many things like we have recognized same-sex marriage and accepted same-sex marriage in many countries in worldwide, and also society also accepting like other changes, other things in other genders, not only man, woman, so the bi-gender and others in society is accepting, and they are coming forward as well as. In addition, the legal status of the homosexuality or the transgender status also different. Some countries legalize homosexual marriages and they are accepting. So the overviews of my lecture today. So we are going to talk about biological sex, gender identity, gender expression, sexual orientation, and sexual behavior. Okay, what this gingerbread person is saying. So the first we talk about the biological sex. So the what we see male, female, or it could be intersex person. And then the sexual orientation comes. Sexual orientation means romantically to whom we are attracted to. Sexually, but whom we are attracted to in sexual orientation. It could be homosexual or the heterosexual, bisexual, or there may be a person who's not sexually attracted to anybody. So, and there are people who have shown pansexual attraction. So it varies with the man and woman. Then what is the gender identity? Gender identity is like how we internally, how we feel about, how the person feel about himself or herself, like man, woman, or non-binary. Maybe not neither man or woman, how they identify themselves. Then at last at gender expression. Gender expression is like how they express themselves, the way they like to call themselves, the name and the pronoun they use, like him or her, like the gender expressions. The way they dress could be different. That's the gender expression. So there are different terms: sex, sexual orientation, gender identity, and gender expression. Okay, biological sex. So this is the sex refers to the biological and physiological characteristics. That could be male, female, or intersex. This is assigned from birth. And there are intersex variation. This happen like in the intrauterine life, especially early intrauterine life, due to some biological event. There could be variation in biological sex. So the people born with intersex organs, so the difficult to differentiate whether a male or female. And the most people with this intersex condition, they come into medical attractions, and the parents are worried, and doctors noticing something different, so they are going to act on it, do the hormonal evaluations and do some corrections and all. So these are some examples of intersex organs. I think pediatricians, they come across these cases. I think rather than using the differences of sex development, the better term is the differences of sex development. So these are the disorders of sexual differentiation. These happen when it is not completed during the intrauterine life. So it's not very common, but there's a noticeable genital ambiguity among them. So we cannot recognize, looking at their genital, whether it's a male or female. So long list of differences of sexual developments are there. We heard about many of these things during our pediatric lectures and all. Congenital adrenal hyperplasia, 5-alpha reductase deficiency. There are many differences of sex developments. So what happened, like after the hormonal evaluation, sometimes they can they medically corrected it, or otherwise they do it, they go for surgical correction. So what's happening to it? There's something called intersex autonomy. The people who are born with intersex organs, so because parents pay the attention to it and they consider it as a medical thing, and what happens is they go for a surgical correction. Sometimes following these surgeries, they have to undergo like not one surgery, and also can complicated with some infections and things, repeated trauma. These intersex children have to go through this traumatized procedure if they have to undergo this sex correction surgery. So the people came out in world, and they think they have to wait till they take the decision whether to be a girl or a raised as a boy rather than someone else taking decision for themselves. Uh, so they talk about this. Child Convention Right Committee, I think in the German, now they have stopped intersex correction surgeries till the child grow up and decide which gender he is going to take. And this man, I think this is in 2018, it's in California, senator, that their state also, they pass a policy about bodily autonomy and dignity and choice act about intersex children. It's a senator in California. Okay, let's understand gender and gender identity. Actually, gender is a social construct. It's like the way they raise us, so there are men appropriate things and the women appropriate things, and also there are some fluid. These are changing with the time as well. Like with the time, the things are changing. It could be masculine or feminine gender categories or androgynous like gender categories are there. As I said, the way we brought up a girl child and way we brought up a boy child is also affecting these things. And their roles, what they expect, what we expect from the society from them, but over the time, these tasks and expectations are changing. Next, we come to gender identity. As I mentioned earlier, it refers to person innate and internal deeply felt sense of being men or women. Psychological sense of self. Most commonly what we see is gender identity go with their sex, biological sex, but that is not always. So sometimes their gender identity can change from their biological sex. Few gender identity terms, so that I'm not going to talk like as we have very few minutes more. So the agender, bigender, there are trigender, demigender, like there are many gender identity terms. Then gender expression, like how they express themselves, their hairstyle, the way they dress, the body language, how they speak, and the pronoun we use, he or she, like that. That's a gender expression. Then sexual orientation. Emotionally or romantically, we could be attracted to our opposite sex or same sex, sometimes for the both sex people, or sometimes there's no attraction at all. Heterosexual, homosexual, bisexual, non-sexual are sexual orientation categories we come across. The Kinsey scale is the scale we use for this homosexual and heterosexual rating scale. This was developed in many decades back. 1948, this Kinsey scale was developed. So this is the description. Like it has like 7 to 8 categories, like exclusively heterosexual and go into exclusively homosexual in. So like from the population, if you take a population, about 3 to 4% of population could be homosexual, lesbian or gay people. Among us, the population 3 to 4% have sexual attraction to same-sex people. And also if we take like there can be sexual fluidity also, so like attraction fluidity also, like the literature says 4 to 11% of population can have some kind of sexual attraction to the same sex person in their life at some stage of their life. So it has a fluidity. They may be turned into a complete homosexual person, or could be changed into again a heterosexual person, but it's usually the homosexual percentage in population is around 3 to 4%. Because of some biological and behavioral structural things, sometimes they are at high risk for sexually transmitted infections and HIV. So that's why we are talking about them in our key population categories as well. Sexual behavior. That's what do you do in sex, what you do sexually. So like could be vaginal, anal sex, oral sex, like that. What are the important groups in sexual and gender diversity? It's very important understanding that sexual and gender diversity by and doctors can easily identify these facts. There's a few examples. So Danny Mendelsohn is a famous author who's having the intersex person, and she's a famous author. And Semenya is, we know, I think most of you familiar with her face. She's two times Olympic gold medalist and 3 times world athletic champion on 800 meters. Her assigned birth assigned sex at birth was a female, but she is a XY person born with a 5-alpha reductase deficiency. So she has a problem in her testosterone conversion into a DHT due to deficiency, and she was identified as a girl at a birth and raised as a girl, and she ran for 800 meters and won gold medals. And because of these things, Olympic Committee, especially when the transgender people or the intersex people come and play, especially in women events, so the Olympic Committee is to make a new framework for them. Because we know many women, the biological sex and their gender expression, everything women, but sometimes due to testosterone and steroids and levels, sometimes they have to be excluded from the games because of the hormonal level. Meanwhile, the people with intersex and who are born as a male also running for female events, sometimes transgender people, they also, so they come into conclusion in this is applied from 2004 Athens Olympic, what they think about, like if a transgender person or intersex person come and play in, for the World Athletic Forum, so they have to be like completed on their sexual transition, like they have acquired their desired gender at the time of the game, and as well as legal recognition also should be completed, and also their hormonal level should be in a correct level in assigned gender, rather than having very high testosterone level, which is very advantage for them to win a game. Otherwise, checking for their sex organs, doing testosterone quantification and all those things, like many athletes are against it because it's traumatizing them. So doing this, so they come into such a framework since 2003. Again, she is also someone with the Klinefelter syndrome and a famous celebrity. So the men who have sex with men, MSM. It's a myth that MSM are intersex. So MSM, so that what they have is their sexual orientation is towards the same-sex person. Same happen in lesbian. So their sexual orientation is towards someone in same sex. But when it comes to lesbian, we see more sexual fluidity, because sometimes they are married. Throughout their lives, they are married and having children. At some stage of life, sometimes they change their sexual orientation and marry the same-sex person. We know this. We know that Sonali Dhanadiyagala, who's the author of The Wave, you have heard. She's married, had 2 children. After that traumatic incidents after tsunamis, it's a famous economist. And now she is married recently to her girlfriend. And even the famous Twilight actor Christine also, now she had many boyfriends. Now she is living with Dylan Mayer, like that. Everyone knows about Ellen and Rosie as well. So, like during their lifespan, sometimes they had a very good relationship with men, and after that, now they are having lesbian relationships. So, we see more fluidity within lesbian relationships. Transgender. So we call it in Sinhala Sankranti Lingika transgender or transsexual. It's often abbreviated as trans person. Is someone whose gender identity or gender expression does not correspond with their sex assigned at birth. So this, especially at the young age, young adult age, they face a lot of dysphoria. They cannot recognize what's happening inside, because their biological sex is different, but what they want to express is different. So during this transitioning phase, they face a lot of gender dysphoria. So and we see male to female transgender people, we see female to male transgender people as well. So the cisgender is the original gender, cisgender male or female. So in Sri Lanka, it's like 0.007 is the percentage of population who is transgender people. All over the world, it's always less than 1%. You have seen many people using different terms. India, they call it hijra. Then Thailand, like you call them lady boys. You see many people, transgender people, but everywhere it's less than 1%. Even if you take Thailand, it's something around 0.3%. So they are the problem. So they have some problem in selecting the right bathroom and all. So some countries, they have created gender neutral toilets, especially in clinics and all. Even in our Colombo clinic also, we sometimes face problems if the transgender people are coming. We have male and female toilets. So it's a new trend to have gender neutral toilets as well. Can see she's I think few years back she was the prettiest trans woman in Thailand, and also many of you are familiar with Ashley Heath. Ashley Heath is the famous Calvin Klein model, born as a female, biological female, and now it's a trans man. There are famous people, and this is my last slide. I think there's something called gender queer. So they are questioning about their gender. They are like they don't assign themselves into a female, male, or trans woman. So they have the gender queer is questioning. They have විවිධ රූපී ගතියක් තමයි තියෙන්නේ. It is very important to respect people's desired self-identifications, and one should never assume another person's identity based on the person's appearance. That's my last message. Thank you.
Thank you, Dr. Iruka Rajapaksa, for that wonderful presentation. And we can allocate few minutes for any questions. So from the audience, if you have any questions.
We have basically abandoned okay, so in resuscitation, I think with COVID we abandoned mouth to mouth treatment even before that also. Let's say we forget about COVID. What is there a chance of let's say in case of your say a close friend or something you have to think about what is there nothing else to be given. Now we talk about just commission on resuscitation because of these concerns. Any sexually transmitted disease that can spread from a breathing or from the breathe or even let's say heart attacks.
So, when it comes to sexually transmitted infections, transmitting through mouth-to-mouth resuscitation, there's a close skin-to-skin contact. Herpes like diseases, oral herpes, HSV1, caused by HSV, can be transmitted through that kind of close contact. But when it comes to HIV, unless there's a trauma, or like visible blood or there's an exchange of serous or blood exchange, there won't be high risk. But if saliva contains very, very low amount of HIV viral load, so I don't think that has a high risk of HIV. But if there's a trauma involved, contamination and exchange of blood, then there's a risk.
So must be the same for HB also.
HB, I think more than HIV. But I think all the healthcare workers are vaccinated against hepatitis.
Any other questions?
Now I think compared to
for HIV virus, how long can they survive the day? HIV virus is like it's not very viable in outside, but when it so it's usually died within like 1 hour, like in external environment. And in the dead body, the thing is there's a wet environment, and so literature shows the rapid decaying of a viral load over the days, but up to 16 days, HIV virus can persist in a dead body up to 16 days. But the thing is, you have to take the point it's gradually coming down. So what we are worried about transmission or acquiring HIV through the occupation and exposure, then it comes a point, there's something called ESSA. So virus should exit from the reservoir and should be exit in a sufficient amount, in a sufficient viral load. Because just having just a one viral particle or sufficient enough to transmit it through occupational exposure. But so what happened is it's gradually coming down. So mostly the later days the viral load is very minimal in the body, but it persists because of the environment, the cold, you store the body in the cold temperature, and also the fluid levels in the
Extremely difficult question. Actually, of course, we can do anatomical certain things, scans and everything, but psychological assessment is very difficult. Very difficult, challenging course. So once the client says that I am unable to have a sexual life due to these things, very difficult to defend him also. I have I have certain cases they came to me and sometimes judges refer. So very difficult to say that this patient is having dysfunction or important. Um, yeah, actually, there are two components. Physical components, of course, we say, and then it's okay. You can test maybe testosterone, lipid levels, cardiac function, renal function, and all. But then we have to go to psychological assessment as well. So we can come to a conclusion. We can come to a conclusion. Some people say it's a common common challenge. They say I can't do. I'm having this function. So when people do, they don't get a chance actually. Dr. Karim, do you have any other thoughts to that question? In the course, they challenge.
Actually, that is very difficult. You can't prove, but you can prove the anatomy and vasculature, and you can do the scanning Dopplers and systolic Dopplers or electric Doppler. Different techniques are there to you can still say that this is the anatomically or even the physiological role also very difficult. But anatomically, you can see the structures are okay, but you can't comment on the psychological aspect in the erection of it. So that's what we try to show you.
Any other questions?
Most of these child abuse cases we see now are those due to some kind of hurting due to some kind of sexual perversion, or are they under influence of some kind of substance?
it's very difficult to understand. So for an adult to have sex with a child, how can we enjoy sex with a so I still think a lot of substance abuse is going on, and that's even the opposite of that, having raping a lady of 85 years old or something like that. Is that because of their increased sexual perversions or right? So it's very again difficult areas. Uh, the now trends we need to study these people, the perpetrators, and do the mental state examinations and see where the issues are. And sometimes we can't just pick one or two these are the causes of this type of people. But it's a variation in generally the sexual preference and sexual attraction variation. So the variation is in, they have the object and the action. So if the object, the selected object is a child, and then the planning for an action. So that is, we know the variations in the society, but it's very difficult to identify what causes that type of behaviors in a person. So that part is very difficult. So we still consider that are within the diversity of the human sexual preferences or even sexual orientation. And we in psychiatry also they consider them as different paraphilic situations, and they try to manage it. But why they have this paraphilia or the different attraction for different type of people is very, I think we can, this is something the brain chemical, I can say the brain chemicals or say related to psychiatric mental status. So then in the society those different people are there. So to control it, the law is the strongest one that we have to do that. So we have to pressure, societal pressure and cultural pressure, as well as the legal pressure to maintain that type of behaviors in the society. So that's what we can do, but the process one is very difficult to do.